Imagine a massive multi-lane highway running right through the center of a major city.
Right, like an 8-lane interstate or something.
Yeah, exactly. And traffic is flowing perfectly,
Yeah.
right? Until suddenly all 8 lanes just come to a complete catastrophic standstill.
A total gridlock.
Total gridlock. But here's the weird part. If you deploy a news helicopter to trace all those stalled cars back to where they came from, you find out the gridlock didn't actually start on the highway. Every single vehicle causing the jam came from a tiny, quiet residential driveway, like miles and miles away.
That is a logistical nightmare.
It really is. But that strange logistical nightmare is the exact physiological reality of what we're talking about today, a pulmonary embolism, or PE.
Yeah.
It's this life-threatening blockage in the lungs that, well, almost never actually originates in the lungs.
Right. It's honestly the ultimate diagnostic chameleon in vascular medicine. And, this is why having a really strong grasp of the underlying mechanisms is just so vital for you as a listener. Because you're dealing with this sudden silent threat. It mimics, a dozen other conditions. And the source of the danger is completely disconnected from the actual site of the damage.
Which is exactly why you and I are on a mission today to decode this. Welcome to today's deep dive. We are pulling from an incredible stack of sources for you to figure this out.
Oh, yeah, we have some great material today.
I've got a high-yield final MBBS review, and that's packed alongside the absolute latest clinical pearls from the AHTEST-CC, the ESC 2024-2025 guidelines, and the CHEST guidelines.
Yeah, and these sources, they paint such a fascinating picture of how the body can just suddenly turn against itself.
So where do we start?
Well, to ground the discussion, we really have to look at the fundamental architecture of a PE. Like, at its core, this is an obstruction of the pulmonary arterial circulation.
Right.
And the immediate, the very first consequence of that obstruction is a severe VQ mismatch.
Okay, let's break down the mechanics of that mismatch real quick for the listener. So the V is ventilation, right? The physical air actually arriving down in the alveoli.
Exactly.
And the Q is perfusion, so the capillary blood flow that arrives to pick up that oxygen. And in a healthy state, those two are perfectly coupled.
But when a thrombus lodges in the pulmonary artery, it creates an absolute blockade. So suddenly you have this lung segment that is perfectly ventilated. It's full of fresh, oxygen-rich air, but the perfusion just drops to zero.
It basically becomes functional dead space.
Right. The blood simply cannot reach the oxygen, and the physiological domino effect from that mismatch is violently fast.
Because the blockage isn't just stopping oxygen exchange, it's creating this massive backup of pressure, right?
A huge backup.
The pulmonary vascular resistance just skyrockets. And the right ventricle, which, is a relatively fun-walled chamber, it's only designed to pump against the low resistance of healthy lungs, it suddenly hits a brick wall.
And that thin right ventricle, it just cannot handle sudden acute afterload. It dilates rapidly to try and compensate. And when it stretches that much, the interventricular septum, the wall that separates the right and left sides of the heart, it actually bows inward.
Oh, wow. Into the left ventricle.
Into the left ventricle, yeah.
Which means the left ventricle can't fill properly.
Exactly.
And if the left side can't fill, it can't pump blood to the brain or the body, which leads straight into obstructive shock.
Right. It's a mechanical failure.
Okay, let's unpack this, because if the lung and the heart are really just the victims here, the innocent bystanders catching all the debris, we need to trace this back to the source. Going back to our highway analogy, we have to look at the residential driveway.
Right, the origin point. And in about 90% of PE cases, that origin is a deep vein thrombosis, a DVT, specifically in the proximal lower limbs.
So we're talking the femoral, iliac, or popliteal veins.
Yeah, those big, deep veins in the legs.
But wait, why are the legs always the culprit? Why down there?
Well, the mechanics of it are entirely based on gravity and fluid dynamics. The venous system in the lower extremities has this totally grueling job of fighting gravity just to return blood to the heart.
Right, it's an uphill battle.
Literally. So it relies on the muscular pump of your calves squeezing the veins and these tiny one-way intraluminal valves that prevent backflow. But when that system stalls out, the blood pools. And stagnant blood is inherently thrombogenic.
It just wants to clot.
It initiates the coagulation cascade simply by sitting there. And once a thrombus forms in that deep, wide vein, the real danger is detachment.
A piece breaks free.
Exactly. A piece breaks free, becomes an embolus, and travels up the inferior vena cava. And because it's traveling toward the heart, the vessels are getting larger.
So it passes right through the large right atrium and right ventricle without a problem.
Right. And then it gets fired directly into the pulmonary arterial tree. But that is where the vessels suddenly start to branch and narrow.
So it's like this massive piece of debris flowing down a widening river until it just violently wedges into a narrow delta.
That is a perfect way to picture it.
Now, the sources provide this thrombus mnemonic to map out exactly what kind of debris we're talking about here.
Right, the etiology.
And while over 95% of these blockages are standard, fibrin and platelet blood clots, the sources talk about these rare non-thrombotic emboli that are just wild.
Oh, they reveal some incredible physiological extremes. Take fat embolisms, for instance.
Wait, fat? Like floating in the blood?
Yeah, fat embolisms, they usually follow severe orthopedic trauma, like if you have a shattered femur.
Ouch.
Right. The medullary cavity of a long bone is packed with yellow marrow, which is highly lipogenic. So when the bone fractures, the immense physical pressure forces that marrow fat right into the ruptured venous sinusoids.
Wow.
And those fat droplets coalesce in the bloodstream, they travel to the lungs, and they cause not just a mechanical obstruction, but the severe inflammatory chemical pneumonitis.
That's terrifying. And there's another non-thrombotic anomaly they mentioned, the amniotic fluid embolism.
Oh, right.
Like during intense labor, if there's a breach in the placental barrier, the pressure gradient of a uterine contraction can actively force amniotic fluid, which is full of fetal cells and debris, straight into the maternal uterine veins.
Yeah, and we also see septic emboli, typically secondary to infective endocarditis.
So that's from an infection in the heart.
Right. If a patient has a bacterial vegetation, like growing on their tricuspid valve, just the mechanical force of the heart beating can shear off clumps of bacteria and necrotic tissue,
Jeez.
sending these highly infectious projectiles straight into the pulmonary circulation. I mean, we even see foreign material emboli, like polymethyl methacrylate.
Which is what exactly?
It's a medical bone cement used in joint replacements. Sometimes it accidentally enters the venous system during surgery.
So basically, the lungs are functionally acting as the filter for the entire systemic venous return.
Yeah.
Like whatever falls in the river ends up in the lungs.
Exactly.
But okay, focusing back on the 95% that are standard blood clots, we have to look at the physiological environment that actually allows them to form in the first place. Which brings us to Virchow's triad.
Right, the classic triad. We use the mnemonic SHE stasis, hypercoagulability, and endothelial injury. These three pillars basically dictate thrombogenesis.
Let's look at that first pillar, stasis. Because I'm reading this and, maybe you as the listener are sitting in your car right now or at a desk. Does just sitting still for too long put us in danger? Like, if I'm stuck in traffic for an hour, am I forming a DVT?
No. The clinical reality of stasis is often pretty misunderstood. The guidelines emphasize that clinically significant stasis typically requires immobilization for more than 3 days.
Oh, okay. 3 days is a long time.
Yeah. That sustained immobility allows local hypoxia to develop down in the valve pockets of the deep veins. And that hypoxia triggers the endothelial cells to express adhesion molecules, which kicks off the clotting cascade.
So we're talking about bedridden stroke patients or severe heart failure, prolonged ICU admission?
Exactly. Even the notorious economy class syndrome from long-haul flights is rarely enough to cause a massive PE on its own.
Really?
Yeah, unless it's compounded by the second pillar of the triad, hypercoagulability.
Right, which fundamentally alters the biochemistry of the blood, priming it to clot with just minimal provocation. And the CHEST guidelines highlight a massive clinical pearl here regarding malignancy.
Well, this is huge, yeah.
Because a tumor isn't just this static physical mass, right? It's metabolically active. The sources say many adenocarcinomas secrete tissue factor directly into the bloodstream. They're essentially weaponizing the coagulation cascade and keeping the body in a constant prothrombotic state.
Which is exactly why a sudden unexplained DVT or PE is considered a glaring red flag for an occult malignancy.
Like a hidden cancer.
Right. But aside from cancer, hypercoagulability can also be hormonally driven. Like pregnancy induces a natural hypercoagulal state just to prevent catastrophic hemorrhage during delivery. And that state is often mimicked by oral contraceptives or estrogen replacement therapies.
And then we have the genetic factors. Factor V Leiden is the classic example from the text.
Definitely.
Because factor V is a crucial protein in the clotting cascade. Normally, the body keeps clotting in check using a braking system called activated protein C. It degrades factor V to stop the clot from growing endlessly. But with the Leiden mutation, factor V is structurally altered.
Right. It becomes resistant to cleavage by that activated protein C.
So the braking system completely fails.
Yeah, the coagulation cascade just keeps accelerating. And when you combine a genetic mutation like that with an environmental trigger, you cross the threshold really rapidly. And the fastest way to cross that threshold is the third pillar of Virchow's triad. Endothelial injury.
Right, the endothelium being that single layer of smooth squamous cells lining every blood vessel.
Right.
And underneath that layer is a matrix of collagen. So when a vessel is injured, say, during a total knee replacement, The endothelium is sheared away, and it exposes that subendothelial collagen directly to the flowing blood.
And exposed collagen is an absolute magnet for platelets. I mean, they bind to it instantly, they activate, and they call more platelets to the site.
So orthopedic surgeries are notorious for this.
Oh, absolutely. Because you're not only causing violent mechanical trauma to the local blood vessels, but you're also combining it with postoperative immobilization.
Oh, right, you're hitting two pillars at once.
Exactly. You are simultaneously triggering endothelial injury and stasis.
So the physiological trap is set, the thrombus forms, it breaks away, and it impacts the pulmonary circulation. But translating that internal physiological disaster into external clinical symptoms, that is where the real diagnostic danger lies. Because a PE is a total master of disguise.
It really is. The clinical presentation is notoriously deceptive. I mean, medical education heavily emphasizes the classic triad of symptoms, right? Dyspnea, pleuritic chest pain, and hemoptysis.
Coughing up blood.
Right. But the ESC guidelines are very explicit that this textbook presentation is actually a dangerous myth.
Yeah.
It only appears in roughly 20% of confirmed cases.
Wait, only 20%? I always thought you'd be coughing up blood and clutching your chest.
No, it's surprisingly rare. Relying on that classic triad means missing 80% of lethal clots.
Wow. Okay, so instead of the triad, the sources give us the plural mnemonic for the actual clinical features.
Yeah, much more accurate. Pleuritic pain, leg swelling, hemoptysis, unprovoked, rapid dyspnea, raised JVP, and low oxygen.
And out of all of those, rapid onset dyspnea, just this unexplained shortness of breath, that's the most common feature, right? Present in about 80% of cases.
Yeah, and this isn't just feeling a little winded. This is a sudden, terrifying hunger for air while you're just at rest.
And the physiology driving that dyspnea is super interesting. It's dual layered. First, obviously, you have the hypoxemia from the VQ mismatch. But more powerfully, the physical stretching of the pulmonary artery by the clot actually stimulates these neural sensors called J receptors.
The juxtapulmonary capillary receptors, yeah.
Right, and they send panic signals directly to the brainstem's respiratory center. So it triggers violent hyperventilation, even if your oxygen saturation hasn't fully plummeted yet.
Exactly. It's a neural panic response. And then there's the pleuritic chest pain, which is sharply localized and worsens when you breathe in.
Because of the tissue death.
Right. This happens when the clot is positioned far enough out in the periphery of the lung to cause a pulmonary infarction. That necrotic tissue creates a fierce inflammatory response that spreads to the pleura, which is the membrane wrapping the lungs.
And that membrane is highly innervated.
Very. So when the patient inhales, that inflamed pleural surface drags against the chest wall, and it causes sharp somatic pain.
Now, we mentioned this earlier, but we have to revisit the concept of the unprovoked PE from that pleural mnemonic.
Yes, crucial point.
If a patient presents with these symptoms, but they lack any obvious triggers like no recent surgery, no trauma, no long flights, the guidelines mandate that doctors investigate for hidden disease.
Always. Because the clot is often the very first clinical manifestation of an undiagnosed occult malignancy. The hypercoagulable state preceded the tumor's actual physical symptoms.
That is wild. But okay, the most terrifying presentation they talk about is the massive or high-risk PE. And the distinction here isn't just about the physical size of the clot, is it?
No, it's defined by hemodynamics. A high-risk PE means the patient is in obstructive shock. Their systolic blood pressure plummets below 90 millimeters of mercury. You see syncope, profound cyanosis, and just a very high probability of sudden cardiac arrest.
And the guidelines give a specific exam, Pearl, about that cardiac arrest, right?
They do. It frequently presents as pulseless electrical activity, or PEA.
PEA. So that means the heart's electrical pacemaker is firing perfectly normally. The ECG monitor shows a steady rhythm, but the patient literally has no pulse.
Right. And the reason for that is because the right ventricle is completely blocked by, say, a saddle embolus. It cannot push any volume of blood through the lungs to reach the left ventricle.
So the left ventricle is contracting efficiently, but it's just squeezing completely empty space.
Exactly. There's no blood to pump systemically. Electrical activity persists, but mechanical output is zero.
That is so deceptive. I mean, the heart is firing but failing. The lungs are starving for air, but they sound perfectly clear to a stethoscope. It totally makes sense why clinicians can't just rely on how the patient looks.
You really can't. You cannot operate on clinical intuition alone when the symptoms are this chaotic. You have to use heavily structured diagnostic algorithms.
But if this is so deadly, why do doctors mess around with scoring systems at all? Like, why not just immediately push every single patient who comes in short of breath straight through a CT scanner?
Well, if we connect this to the bigger picture, the hospital infrastructure and the biological toll make that impossible. Massive overutilization of CT scans exposes the population to highly localized radiation.
Right.
And contrast-induced nephropathy, where the heavy iodine dye used in the scan actually damages the renal tubules.
Oh, so the test itself has risks.
Huge risks. And furthermore, indiscriminate scanning yields thousands of clinically insignificant subsegmental clots.
Meaning tiny clots that wouldn't have killed them anyway?
Exactly. But once you find them, you have to treat them, which leads to unnecessary anticoagulation therapies that carry severe spontaneous bleeding risks.
Ah, I see. So the diagnostic pathway have to act as a targeted filter first.
Yes. Step 1 is pre-test clinical probability scoring. We use tools like the Wells score or the Revised Geneva score.
Right, where the physician calculates a hard numerical value based on objective signs, like tachycardia, hemoptysis, prior DVT history, or just whether an alternative diagnosis like pneumonia is less likely.
Exactly. And if that score places the patient in a low or intermediate probability bucket, then they transition to the D-dimer test.
Okay, the D-dimer. The sources talk a lot about this. It's an elegantly precise chemical test, but its utility seems frequently misunderstood.
Very often, yeah. It's essentially a highly sensitive biochemical metal detector. D-dimer itself is just a specific protein fragment. It's produced only when the body's endogenous fibrinolytic system breaks down cross-linked fibrin.
Which is like the structural rebar of a blood clot.
Exactly. So if the D-dimer test is negative, the metal detector is silent. And because of its extremely high negative predictive value, you can confidently rule out a clinically significant PE. The biological evidence of clot degradation just isn't there.
But if the detector beeps, if the D-dimer is elevated, it only indicates that fibrin is being broken down somewhere in the body.
Right. It has exceedingly low specificity. Pregnancy, generalized inflammation, recent trauma, severe infection. All of these can trigger cross-linked fibrin deposition and subsequent degradation.
So a positive result doesn't confirm a PE at all. It just acts as the gateway requiring advanced imaging.
Exactly. And there's this really brilliant mathematical adaptation in the guidelines regarding older populations for the D-dimer.
Well, the age adjustment.
Yeah. The physiological reality is that as human vasculature ages, baseline endothelial wear and tear and low-grade inflammation just naturally increase fibrin turnover.
So an 80-year-old naturally has significantly more background noise than a 20-year-old.
Precisely. So to account for this, the standard threshold of 500 micrograms per liter is adjusted for patients over 50. You just multiply their age by 10.
Okay, so an 80-year-old patient utilizes a cutoff of 800.
Right. And this single age-adjusted algorithm prevents massive numbers of unnecessary CT scans in the geriatric population without sacrificing any safety.
That's incredibly smart.
Yeah.
Okay, so if the probability is high or the D-dimer is elevated, then we finally evaluate the baseline imaging.
Right.
And this is where the paradox of the PE truly shines. Let's look at the ECG. The sources mention this TAS-HYRV mnemonic.
Right, to remind us of the findings. But here's the paradox with the ECG. The classic textbook finding taught in literally every medical school is the S1Q3T3 pattern.
Right, but the guidelines say that's actually super rare.
Yeah. It's deeply ingrained in the literature, but it only appears in roughly 20% of acute cases.
So what exactly is S1Q3T3 anyway?
Well, the mechanism behind it is fascinating. When the right ventricle acutely dilates against that sudden pressure overload, it physically alters the anatomical position of a heart within the chest cavity.
It twists it.
It shifts it, yeah. This acute rightward axis deviation manifests electrically on the ECG as a deep S wave in lead 1, a pathological Q wave in lead 3, and an inverted T wave in lead 3.
So it's a marker of acute right heart strain, not a direct visualization of a clot at all.
Exactly. In reality, the most frequent ECG finding is just simple sinus tachycardia, as the autonomic nervous system desperately increases the heart rate to try and compensate for the falling cardiac output.
Makes sense. Now, what about the chest x-ray? Because that presents an even more deceptive paradox.
Oh, yeah, because the chest x-ray in a massive life-threatening PE is almost always entirely normal.
Normal.
Completely normal. X-rays visualize tissue density, fluid, bone consolidation. They cannot reliably visualize intravascular hemodynamics.
I see.
You might occasionally see a Westermark sign, which is this focal area of pulmonary oligemia, basically hyperlucency, where the lack of blood flow makes a segment of the lung look abnormally dark.
There's no vascular markings.
Right, but that is exceptionally rare.
Which introduces one of the most powerful diagnostic deductions for doctors. A patient exhibiting profound hypoxemia with a perfectly clear chest x-ray should dramatically elevate your suspicion for a PE.
Yes. If the alveoli aren't filled with fluid or pus, the barrier to oxygenation has to be vascular.
And that deduction leads straight to the gold standard of imaging, the computed tomography, pulmonary angiography, or CTPA.
The CTPA, yes. It provides high-resolution, three-dimensional mapping of the pulmonary arterial tree. Intravenous iodine contrast is timed perfectly to illuminate the pulmonary arteries bright white.
So a thrombus will just appear as an abrupt intraluminal filling defect, like a stark, dark void sitting right in the middle of the bright contrast stream, or a massive saddle embolus straddling the bifurcation of the main pulmonary trunk.
Exactly. You literally see the blockage. However, the CTPA is not universally applicable.
Because of the radiation and the contrast dye?
Right. They require alternatives. The VQ scan is prioritized for pregnant patients to minimize fetal radiation exposure. It uses inhaled radioisotopes to map ventilation and injected isotopes to map perfusion, searching for that definitive mismatch.
And it's also the primary alternative for patients with severe chronic kidney disease, right?
Yes, because the iodine contrast of a CTPA would precipitate acute renal failure in those patients.
What about patients who are hemodynamically unstable, like the ones in shock who physically can't survive the transfer down to the radiology suite?
For them, bedside echocardiography is utilized. The ultrasound probe gives a real-time, dynamic view of the mechanical strain. You can visualize the massive dilation of the right ventricle, the bowing of the septum we talked about, and critically, the McConnell sign.
The McConnell sign. Break that down for us.
It is a brilliant mechanical indicator. The right ventricular free wall is facing such extreme acute afterload that it becomes severely ischemic, and freezes it becomes akinetic.
It just stops moving.
Right. However, The very apex of the right ventricle is anatomically tethered to the hyperdynamic, robust left ventricle. So the apex continues to contract vigorously while the rest of the wall is paralyzed.
Wow. So it's like a visual signature of the strain.
Exactly. And alongside imaging, biomarkers like troponin and BNP brain natriuretic peptide provide crucial prognostic data.
Right. They don't diagnose the clot, they quantify the collateral damage. High BNP indicates the muscle fibers of the right ventricle are physically stretching to their absolute limits, while elevated troponin signals actual microinfarctions of the cardiac muscle tissue.
Yes, it stratifies the patient's immediate risk of cardiovascular collapse.
So we have mapped the entire treacherous path of this pathology, from the deceptive origins of venous stasis down in the lower extremities, through the biochemical triggers of Virchow's triad, past the intensely confusing clinical mimicry of the symptoms, and into the rigorous algorithmic precision required to definitively identify the obstruction.
We covered a lot of ground, and the overarching lesson from these guidelines is that pulmonary embolism requires absolute clinical vigilance. You just cannot wait for the textbook triad of symptoms.
You have to recognize that sudden, unexplained dyspnea is a siren.
Yes, and you have to respect the physiological chain reaction that can take a patient from a swollen calf to pulseless electrical activity in a matter of hours.
So what does this all mean for the listener?
Well, the ESC guidelines emphasize a final golden rule for clinicians navigating this landscape. If the clinical suspicion for a PE is high and the patient does not have an absolute contraindication to anticoagulation, do not delay treatment while waiting for definitive imaging.
You initiate heparin or the appropriate blood thinner immediately.
Immediately, you arrest the propagation of the clot first. You confirm the anatomy second.
That protocol saves lives by prioritizing physiological reality over diagnostic finality. And, reflecting on the hidden origins of these clots, specifically that connection between an unprovoked DVT and an occult malignancy, it leaves us with an incredible frontier to consider.
Oh, the diagnostic potential embedded in the thrombus itself.
Precisely. If an unprovoked blood clot is often the very first alarm bell for an asymptomatic cancer, it makes you wonder about the future of molecular pathology.
Yeah.
Could the embolus of the future be extracted and genetically sequenced the moment it's removed? Could a simple blood clot pulled from a patient's leg act as a highly specific biological map, pinpointing the exact genetic signature and location of an invisible tumor long before a CT scan or a biopsy could ever find it?
Using the byproduct of the pathology to unmask the hidden source. It turns a lethal complication into a targeted early warning system.
A fascinating evolutionary step for internal medicine. Thank you for joining us on this deep dive. As always, stay curious, keep questioning the physiological mechanics around you, and we'll see you next time.